Okay, let's dive right into this. Picture this. You've got a patient in your chair, and you really need to get a good look at their peripheral retina. So naturally, you reach for your dilating drops. It's totally routine, right? Well, what if I told you that simple, everyday action actually carries a hidden, high-stakes clinical dilemma? If you dilate an eye with an occluded or even just anatomically narrow drainage angle, the iris is going to bunch up, block the outflow of fluid, and bam, you could literally trigger a blinding attack of acute angle closure glaucoma. So, welcome to this explainer. Today, we're going to master the clinical countdown of anterior chamber angles so you never ever make that sight-threatening mistake. Now, our entire journey today is based on the incredibly brilliant clinical lectures and texts of Dr. Dirk J. Boozin. He's the renowned author of the Southern Africa Guide to Topical Ophthalmic Drugs. We're relying heavily on his expertise to map out exactly how to assess these crucial microscopic structures safely and effectively. All right, here's our syllabus for today. First, the dilation dilemma. 2, mapping angle landmarks. 3, the Schaffer grading system. 4, the 2+ rule. 5, comprehensive clinical assessment. And finally, number 6, building a practice eye. Section 1, the dilation dilemma. You know, as clinicians, we carry an immense responsibility before putting a single mydriatic drop in a patient's eye. We absolutely must be certain that the eye's drainage system can actually handle the physical changes that dilation causes to the iris. But you might be wondering, okay, how common is this occlusion risk really? Well, according to Dr. Boysen's data, about 0.64% of adults over 60 have anatomically narrow angles that might occlude if you use mydriatics. Now, less than 1%. That number might sound tiny, right? But think about it. If you're seeing dozens of patients a week, you are mathematically guaranteed to run into this risk on a regular basis. To put it simply, this statistic is exactly why mastering anterior chamber assessment isn't just a good idea. It's an absolutely mandatory sight-saving skill. Section 2, mapping angle landmarks. So to know if an angle is safe, we first have to know what we're actually looking at, right? Across the entire 360 degrees. Notice how clearly we can see the transition of structures here, from top to bottom. It's almost like looking at a geological core sample. Check out the difference between the non-pigmented and the pigmented trabecular meshwork. Then, right below that, there's the stark white line, that's the scleral spur. And finally, the darker ciliary body band at the very base. Picking up on these distinct color changes and textures, that is your primary roadmap. To permanently anchor these structures in your mind, moving from posterior to anterior, so from the base of the angle up toward the cornea, Dr. Boozin gives us this highly memorable mnemonic, I can't see this stuff. So good, right? It stands for iris root, ciliary body band, scleral spur, trabecular meshwork, and Schwab's line. Just memorize that sequence. Because if you know exactly what order they're supposed to appear in, you're going to know immediately when something is missing or dangerously blocked from view. Section 3, the Schaffer grading system explained. Okay, now that we've got the static landmarks down, we need to actually measure the space between them. And we do this using the Schaffer system, which is essentially our definitive clinical countdown. This system grades the angular width created between the mid-peripheral iris and the angle wall. We start up at a totally safe grade 4. That's a nice, wide-open angle of 35 to 45 degrees. Then, grade 3 narrows down to between 20 and 35 degrees. By grade 2, we hit 10 to 20 degrees. And pause here because this is officially considered narrow and capable of closure. Grade 1 is 10 degrees or less, absolutely dangerously narrow. And finally, grade 0. The angle is 0 degrees, it is completely closed, and the iris is physically touching the cornea. This really brilliantly illustrates the physical reality of that countdown. Look at how the spatial relationships literally change. Up top, you have that wide, safe cavern of a grade 4 angle. But as we move down the scale, the iris progressively creeps closer and closer to the angle wall. By the time we hit the bottom, there is virtually zero clearance. Think about it. If you dilate an eye with that bottom configuration, you are basically slamming the door shut on the eye's only exit for fluid. Moving on to Section 4, the 2+ rule. So where exactly do we draw the line? When do we say a hard no to dilation? Well, that brings us to the absolutely crucial 2+ rule. This is a strict clinical standard requiring that you must have visibility of at least 2 angle structures in all 4 quadrants of the eye. In practical terms, that means you have to clearly see 100% of the trabecular meshwork. If you see anything less than this, you've got to stop, reassess, and really consider withholding those dilating drops.
To really cement this into your everyday clinical practice, let's look at this incredibly direct, uncompromising quote straight from Dr. Boysen's text. With gonioscopy, you need to see 100% of the trabecular meshwork in all four quadrants, i.e. a 2+ angle, before dilating. Guys, this is not a suggestion. It is an unbreakable clinical law, and it's designed specifically to protect your patient from severe harm.
Section 5. Comprehensive Clinical Assessment.
So, knowing the 2+ rule is obviously essential, but how do we actually triage patients to know who even needs gonioscopy in the first place? Well, before you ever pick up a gonioscope, you're likely going to use the Van Heerijk technique at the slit lamp. Notice how a grade 4 or 3 implies the angle is, for the most part, incapable of closure. But, and this is a big but, if you assess a grade 2, where the depth is only 1/4 of the corneal thickness, or a grade 1, that is your immediate glaring red flag. Actually, any grade 2 or below on the Van Heerijk scale means a full gonioscopic evaluation is absolutely mandatory.
And you can see how this philosophy builds into the broader scope of clinical care. Just like we use the Schaffer and Van Heerijk systems to objectively grade the interior chamber, rigorous, level-based grading systems are the universal foundation of safe optometric practice. Take the DEWS dry eye severity grading scheme as a prime example. Moving from level 1 up to level 4, it gives us completely objective clinical science to match up with subjective symptoms. Whether we're talking about dry eye or angle closure, assigning a structured grade just totally removes the guesswork, ensuring a really consistent standard of care.
Section 6. Building a practice eye.
Now, of course, all this theoretical grading means absolutely nothing if you aren't completely comfortable wielding your instruments. Dr. Boysen realized that mastering these clinical skills requires serious hands-on repetition. So he designed a practice eye that you can literally build right now. You just need a few basic everyday materials, some masking tape, 3 high-plus trial lenses, like 2+20s and an 18, a piece of dark cardboard with a little 4mm hole punched out for a pupil, and a printout of a fundus image. That's the whole shebang. Assembly takes, maybe 2 minutes? You just stack those 3 high-plus lenses together and wrap them tightly in your masking tape to form an optic module. This specific combo of lenses actually perfectly simulates the immense refractive power of a real human eye. Pretty cool, right? Once they're taped up, you just pop your cardboard pupil on the front and attach your fundus image to the back. Next, you mount this whole DIY contraption right onto the headrest of your slit lamp. And just like that, you can grab your Volk lens and practice viewing the fundus. It requires the exact same focal distance, alignment, and physical dexterity as examining a living human eye. And honestly, the best part? As Dr. Boysen points out, this is a very compliant patient. It won't blink, it won't tear up, and it definitely won't complain. So you can really just take your time and build that vital muscle memory needed for perfect clinical assessments. Which brings us to the ultimate question. We've mapped out the landmarks, we've counted down the Schaffer system, and we've permanently locked in the 2+ rule. So the next time you've got a patient sitting in your chair and you go to reach for those mydriatic drops, will you know exactly what's hiding in their angle? Because at the end of the day, the difference between a routine exam and a full-blown medical emergency comes down entirely to what you can see. Keep learning, keep practicing, and protect that vision.